to my channel Grow With Me. So as you all know that I am a MBBS graduate. I am preparing for my NEET PG, but due to this corona pandemic going all around, the exams are very postponed, like from Jan to April to we don't know now where and when it will be. So I have thought to make some YouTube videos regarding our studies, so that we can I can also revise and you can also revise with me. And I have started a session called study with me, one day one topic. So we will every day study one topic every day. The next topic I'll inform to you in the previous day in advance, so that you can just have a glance over it and look at these videos. It will be very helpful. I'm not going to talk about every topic in very detail. Just I have selected some important topics from some important subjects, and every day, like if one day a major subject, then the next day a minor subject. So how it's gonna be useful to you is you just have to listen to this video and just don't take any notebook or any notes or nothing. Just listen to this video and recollect. The best way to memorize things, or to the people say that they don't remember things, just recollect what you have read. So if today I am going to talk about thyroid, so just अभी thyroid करेंगे. तो thyroid में I'll teach you the important things in thyroid, and then you just have a overview the some time before, and then just start with this. Okay guys, so we'll start talking about thyroid from general surgery. So what we will talk in the first introductory part is that we will discuss about its anatomy, then like nerve supply, blood supply and all, and then we will study the main thyroid examining positions and the names. That is very important. It's asked very frequently. And then about some brief about the thyroid surgery, the methods. And then tomorrow we will see about the thyroid benign neoplasms, right? So blood supply, regarding the blood supply, so the arterial supply of the thyroid is from superior thyroid, middle thyroid and the inferior thyroid artery. And what we have to remember is the inferior thyroid, it also supplies the parathyroid gland, and the blood supply is the superior thyroid, inferior thyroid and the middle thyroid. We just have to remember that the inferior thyroid also supplies the parathyroid gland because it is inferiorly located. And we have the thyroid IMA artery. It is a branch of the arch of aorta. It comes from the arch of aorta. Now venous drainage. Venous drainage is from superior thyroid, middle thyroid and inferior thyroid. Now middle thyroid is present in only 20% of cases, and it is a very important artery which is first ligated during thyroidectomy. Okay. Now what are the nerves? So we have two nerves draining supplying the thyroid. That is external thyroid, external laryngeal nerve and the recurrent laryngeal nerve. Please don't mistake me if I do something wrong, because I am also a student like you. Just I'm posting this video for you to revise. So the external laryngeal nerve, it is a branch of the superior laryngeal nerve, and then superior laryngeal nerve, and it supplies only the cricothyroid. That is it is the tensor of the which is the tensor of the vocal cord. It only supplies the cricothyroid, and then cricothyroid, it is used to speak at a very high pitch. Now what we have to remember is अभी एक्सटर्नल लैरिंजियल नर्व है, वो सुपीरियर पोल को सप्लाई करेगा. तो सुपीरियर पोल को सप्लाई करेगा, तो इट रन्स अलॉन्ग विद द आर्टरी, दैट इज द सुपीरियर थायराइड और एक्सटर्नल लैरिंजियल साथ में जाएगा. तो अभी ग्लैंड है, ठीक है, तो ग्लैंड के बाजू में दे आर फार अवे, लाइक अभी ये मेरा ग्लैंड है, तो यहाँ पे वी हैव द एक्सटर्नल लैरिंजियल एंड द सुपीरियर थायराइड, एंड जैसे जैसे ऊपर जाएगा तो साथ में हो जाएंगे दोनों. तो the why we have to remember is this, because अभी when we are doing thyroidectomy we have to ligate both the nerves, when like both, if we have to ligate the artery close to the gland, so that we don't injure the एक्सटर्नल लैरिंजियल नर्व. तो अभी ऊपर करेंगे तो दोनों साथ में, तो दोनों को लाइगेट हो जाएगा, इसलिए वी हैव टू ligate क्लोज टू द ग्लैंड वेयर दे आर अवे फ्रॉम ईच अदर. ऐसे याद रखना है कि क्लोज टू द ग्लैंड, अवे फ्रॉम ईच अदर, एंड अवे फ्रॉम द ग्लैंड क्लोज टू ईच अदर, ऐसे याद रखना है. नाउ रिकरेंट लैरिंजियल नर्व. अभी रिकरेंट लैरिंजियल नर्व इट सप्लाइज ऑल अदर मसल्स एक्सेप्ट क्रिकोथायरॉइड, क्योंकि क्रिकोथायरॉइड सप्लाइड बाय एक्सटर्नल लैरिंजियल नर्व. अभी recurrent laryngeal nerve it also supplies the vocal cords below the vocal cord का sensory supply भी it is given by recurrent laryngeal nerve. अभी कैसे याद रखना है कि अभी सुपीरियर पोल में एक्सटर्नल लैरिंजियल नर्व, तो इन्फीरियर पोल में अपने पास रिकरेंट लैरिंजियल नर्व. एंड देयर इज वन ट्रायंगल विच इज कॉल्ड एज बेयर्स ट्रायंगल, इन विच वी हैव 3 structures, that is inferior thyroid artery, and then common carotid artery and recurrent laryngeal nerve. એટલે recurrent laryngeal nerve के साथ और 2 आर्टरीज है, inferior thyroid and common carotid. अभी अभी अपने पास दो जाते हैं, लेफ्ट एंड राइट. तो अभी लेफ्ट बहुत लंबा होता है, तो लेफ्ट थायराइड लाइक लेफ्ट लैरिंजियल नर्व इट विल वाइंड अराउंड द आर्च ऑफ एटा, एंड राइट सब क्लेवियन, क्योंकि अभी आर्च ऑफ एटा एक ही है, तो एक साइड लेफ्ट वाइंड करेगा एंड राइट साइड सब क्लेवियन आर्टरी वाइंड करेगी. And now we have to see the injury, the site of injury of recurrent laryngeal nerve. It is injured most commonly close to the Berry's ligament, which is a condensation of the pretracheal fascia. It is also called as Zuckerland tubercle, which is over the posterolateral aspect of the gland. ठीक है, ये अपना एनाटॉमी हो गया. 3 arteries, 3 veins and 2 nerves. ये इतना याद रखना है. मेनली नर्व याद रखना है. एक्सटर्नल किसको सप्लाई करता है, रिकरेंट किसको सप्लाई करता है. ओके, सो थायराइड का क्लिनिकल एग्जामिनेशन वी विल डू नाउ. अभी उसमें फर्स्ट अभी कोई भी इंस्पेक्शन करना है तो वी हैव इंस्पेक्शन एंड पाल्पेशन. इंस्पेक्शन के लिए वी जस्ट हैव टू लुक एट द थायराइड ग्लैंड. तो वी आस्क द पेशेंट टू स्वॉलो, ऐसे स्वॉलो करना है, एंड देन वील लुक फॉर द gland mobility and stuff. So gland mobility है कि नहीं, and then we have to look for any lower like aspect of the thyroid gland तक देखना है. And if mobility अब नहीं दिख रहा है उनको, उसको mobility, तो we have to do second is palpation of the gland करके उसकी lower limit देखनी है. एंड देन अगर उसमें भी दिखाई नहीं दिया तो इट सजेस्ट दैट इट इज़ अ रेट्रोस्टर्नल, पीछे रेट्रोस्टर्नल क्वाइटर है. Now in palpation, what we do is we have 3 methods how you do a palpation, and why do we, क्यों करना है, why we have to first learn why and how. कब करना है, when, तो you know if there is any swelling or if patient comes with some clinical symptoms of thyroid. When we know why करना है, तो why because we want to see the nodularity and the swelling, that is the of the thyroid gland. nodularity और lower limit भी हमको inspection में नहीं दिखाई दिया, तो we will see the lower limit. Now we have 3 methods, that is Pizzilo's method, Trial's method and Lahey's method. ठीक है, so we'll study one after other. So in Pizzilo's method, what we do is we ask the patient to take his hands and behind his head occiput area and press, उसको ऐसे press करने को बोलना against his occiput area, so that ये जो है it comes forward, so he can palpate the gland. So if it palpates and if there is a uniform enlargement, it can be 3 causes, that is colloid goiter, then uniform enlargement of the goiter and physiological goiter, that is, and Hashimoto's disease भी हो सकता है. So 3 causes. नाउ सेकेंड इज लाहिस मेथड. तो फर्स्ट पिजिलोस हो गया. लाहिस में क्या करना है, एग्जामिनर पेशेंट के फ्रंट साइड में ही विल स्टैंड एंड ही विल एक साइड ऐसे हाथ रख के ही विल चेक फॉर द नोड्यूलरिटी एंड स्टफ. अब दोनों हाथ नहीं रखना है यहाँ पे अभी, नहीं तो वेगस को टच करके सिनकोपल अटैक हो जाएगा, गिर जाएगा. तो वी डोंट हैव टू टच बोथ द साइड साइमल्टेनियसली. एक साइड करना है फिर दूसरे साइड पापिट करना है, ठीक है. And third method is Kryle's method. Kryle's method maybe the examiner stands in the front and he looks for the nodularity, but how he will ask the patient to ऐसे swallow करना है, and then while swallowing ये thumb जो है we have to keep here to check for the ऐसे करना है तो nodularity and lower limits palpable होगा. Now we have the eye signs of the thyroid. Okay, so we look for the eye signs. Abhi eye signs mein there are many signs, but we have to remember the important 4 ones that are the von Graeff's sign, Stellbach's sign, then Mobius sign and Joffroy's sign. Okay, there are 4 signs. Now von Graeff में क्या करना है, we have to ask the patient to like अभी moving object रखना है. अभी मूविंग ऑब्जेक्ट के लिए वी हैव टू आस्क द पेशेंट और द एग्जामिनर विल कीप हिज हैंड अबाउट द हेड एंड प्रेस करेगा उसका हेड, एंड देन ही विल आस्क द मूविंग ऑब्जेक्ट टू फॉलो, ऐसे ऐसे फॉलो करना है एंड ऊपर से नीचे तक. तो अभी जब ऊपर जाएगा तब तो ये ऊपर जाएगा, द आई ब्रोज विल गो अप, एंड देन व्हेन ही विल टेक द ऑब्जेक्ट डाउन, the upper eyelid will not follow the moving object because eyeballs इतने बड़े हो जाते हैं, the exophthalmos, so the upper eyelid will not follow down, so that is called as von Graeff's sign. तो ऊपर देखता है तो बराबर है, नीचे आते आते वो that will the upper eyelid will not follow the object, that is von Graeff's sign. Now the second is Joffroy's sign. So Joffroy's sign is अभी ऊपर देखने को बोला कोई ऑब्जेक्ट है, तो now I have the wrinkling of my forehead, but in the thyroid patient there will not be any wrinkling of the forehead क्योंकि eyeball इतने बड़े बड़े होते हैं कि he will straight away look upwards ऐसे without wrinkling of the forehead. Okay. Now the third is Stellbach's sign. Stellbach's sign is because of the big eyeballs there is infrequent blinking. Blinking will be very infrequent. Now the fourth, that is the Mobius sign. It is a very severe sign of hyperthyroidism. So what is that sign is the abhi ek pen like any object which is we have to keep at a distant focus, and then suddenly we have to keep in the sight of the object, that is what we are seeing is convergence. So accommodation dekh rahe hai, so convergence ke liye like we have to keep it very far away and then suddenly in the light, and in the thyroid patient he will not be able to see, he will not be able to do a convergence because the eyeballs, due to the big eyeballs, they convergence की ज़रूरत है, but they will adapt itself. So these are the 4 signs in which we have to do in a thyroid disorder patient. Now what we will do is next is the investigation. We will study about the investigation in a thyroid patient. Now what are the अभी एक patient आया thyroid का, and उसमें अभी we have to see like symptoms क्या है, if he is hypothyroid or hyperthyroid. If he is hypothyroid, the patient will have constipation, weight gain, dry skin, alopecia, and then if it's a female, she will have menorrhea, that is polymenorrhea, heavy menstruation and thing. And if it is hyperthyroid, the patient will have diarrhea, the reverse symptoms, that is diarrhea, heat intolerance, weight loss, and then he will have the exophthalmos. It is a sign, but still big eyes, and if it's a female, she will have oligomenorrhea. So these are the symptoms which we have to see the patient comes. Now first investigation or the initial investigation, what we ask the patient to do is for the thyroid function test, which includes TSH, free T3, free T4, because bound we don't rely on it much because it's bound to the albumin. We only do the free T3 T4. Now second what we do is the ultrasonography. Now ultrasonography neck we have to check for the gland enlargement, nodularity, vascularity, then the lymph nodes. So lymph nodes, nodularity देखना, vascularity, and for the gland enlargement we have to do the ultrasonography. And if we think, or if ऐसे दिख रहा है, if it's any enlargement or if it's like a tumor growth or a nodule proliferation, so we have to ask for the FNAC. So next investigation would be a FNAC. It is the investigation of choice if any lump or it is seen. Now if the patient has hyperthyroid features and low TSH, so what we have to do as a first investigation is we have to ask the patient for a thyroid scan, because it can be a cold nodule, hot nodule, or any plumber's disease. So we have to ask for a thyroid scan we have to do. And what are included in the thyroid scan is technetium and iodine 123 scan. Now what are the difference? So technetium 99 will tell about the uptake of conveys only about the uptake of the can, while the iodine conveys about the iodinific, that is the uptake, and the organification of the gland, that is कुछ proliferation है कि नहीं and uptake increase हुआ है कि नहीं, that all the iodine 123 will convey. Now FNAC तो अभी किया, तो after USG neck तो अभी FNAC तो आना चाहिए, तो we'll study about FNAC, that's very important, which follows the Bethesda classification. 5 classification है. In that we have 1, 2, 3, 4 and 5 classifications, like 5 numbers we have. In that we have 1 is non-neoplastic. Second उसमें 1 में 1C है, और C means cystic, so cystic है, तो that is also non-neoplastic and cystic. So we have to repeat USG guided FNAC. Second we have non-neoplastic, that is benign tumor. If there is any tumor we have to just follow up. If there is any indicator like उसके like the family history है, anything is there for carcinoma, तो we can operate, otherwise no need. 3 is for the follicular adenoma. FNAC cannot differentiate between follicular adenoma or carcinoma, so we have to do another investigation like true cut biopsy, or we have to frozen section is would be more good, like hemithyroidectomy करके we will go give the tissue for frozen section. Now fourth is that is suspicious of malignancy, and fifth is malignant, and in both we have to do a surgery. In follicular adenoma also the next step would be hemithyroidectomy. Okay, so this is the main I'm covering about the anatomy and about the investigations. The indications for thyroid surgery that we have to study first. So there are 4-5 major indications. That is, first is neoplasm, that is Bethesda classification FNAC 3 to 5 or and 3 to 5, and if there are other indicators like if it's a male sex, fixity, hard texture, recurrent laryngeal palsy, lymphadenopathy, and colloidal, or there is recurrent cyst, we will take as it is an indication. Second is if it is a toxic adenoma. Third is if it is a pressure symptoms are there sometimes, and fourth is the least is the cosmetic, or if the patient needs it. Now what is the position, like the surgery ki position kya hai? So the patient should be in a rose position. Now what is a rose position? It is the patient should be in a supine position with the neck extended, and on the shoulder there should be shoulder blades placed. Shoulder blades placed. The position of the thyroid surgery, that is the rose position. In that the patient should be in supinely position with head should be extended 30 degrees so that the blood flow in the area is less. But what is the problem is due to the elevation there is a risk of air embolism. Second is the patient should be the shoulder के वहाँ पे there should be blades placed, so there is a slight neck extension, and where we will put the incision now. So incision should be put 2 centimeter above the collar suprasternal notch, and it is a collar incision extending from one end of the clavicle to the another end of the clavicle. We have 3 or 4 types of thyroid surgery. That is total thyroidectomy, in which we remove the entire lobe. Second is subtotal. Subtotal is we remove the 2 lobes, but we leave only some part of tissue in both the thyroid gland. And third is near total. Near total is we do the lobectomy plus isthmusectomy, and only a part of tissue is left in one lobe. So that is a near total thyroidectomy. And what are the complications? So the complications are recurrent laryngeal nerve palsy, hypoparathyroidism or hypothyroidism. It is the same for total, near total and subtotal. In all the three, the risk of injury is the same. So after thyroid surgery, we have to re-evaluate the patient for any injury or any hypothyroid or hypoparathyroid features, and we have to give the medications accordingly. So guys, this is the today's video. I have talked to you about the thyroid anatomy, the thyroid clinical examination, about the investigations, and about the different surgeries and their indications. Tomorrow we will meet with again a new topic, and I will put that which subject we are going to study tomorrow in the description box. Stay tuned, stay safe, and enjoy. Bye.